And then the third component is a clinical dashboard, which basically allows healthcare professionals to access that assessment data, but also risk stratify patients, identify deterioration, and then take the right course of action.
That's a lot of information. So, okay, so your sensors pick up a problem with a heart patient. What happens? You call a clinician? How does it work?
Yeah, so essentially, as I mentioned, we're deployed in over 100 sites, and that spans care homes, primary care facilities, community and district nursing, and virtual wards. So for virtual wards, what that looks like, so it's both step up and step down. So to avoid an admission or after identifying early deterioration, to support early and safe discharge. So what that means is if you're a patient on a virtual ward, you are basically going to get the kit with all of the devices, and you are going to receive the training. We take care of all the training and the logistics, and you are going to do the assessments yourself. If you're in a care home, the carer will do them. If you're in community and district nursing, it would actually be the carer or the health worker that will do it. And the kit is basically, in addition to all those sensors that I mentioned, it has a mobile phone which comes with the preloaded Feebris app, which then sends the data to the clinical dashboard so that healthcare professionals can actually act on that data.
I've got some more questions I want to ask you.
Yeah.
I'm going to rattle through the panel, so don't go anywhere. Clearly you can't, because you're on a stage. It would look embarrassing, wouldn't it? Okay, Lauren Beven, Director of Consulting, Ethical Healthcare Consulting. Interesting fact about Lauren, actually. I do like my interesting facts. And I found it interesting anyway. Lauren's ancestors, or one of her ancestors, had his head put on a stake for trying to overthrow the king.
Yep.
And she says that's one of the reasons why she's so outspoken. I actually think there's a certain regal element to your shoes there.
Yeah.
I mean, look at those. They are really striking, very impressive. Just explain what ethical healthcare consulting does. The clue's probably in the name.
Yeah. So healthcare consulting, which is obviously in the name, but the ethical part of it is that we are partly owned by our staff. And also what we do is we give sort of 50% of our profits last year went back into good causes. Some of those were things that were suggested by our staff, so community organisations in the communities that they live in, and also good causes that we would sponsor, so in terms of hospital charities and other things like that. So it's consulting, but it has, we act on that, and we're in the process of being B Corp accredited and other things like that. So we do take that social responsibility aspect of it very seriously. So
much so that you're set to become employee-owned fairly soon as well. Now, you help the NHS buy tech that helps staff and patients. Now, a good example would be the work you do with virtual wards, which supports patients at home rather than taking up beds, in a hospital environment. Now, I always think examples are helpful. You found out the uptake of these virtual wards was quite low. They come to you and said, sort it out, Lauren.
Yeah, so a lot of the time we can either help or have helped with people selecting the right technology to deploy based on kind of user needs. And because we're totally agnostic, we don't receive, we don't have affiliations with particular tech organisations, so we can be, fairly neutral and impartial with those decisions. And the other thing is when that technology's already been deployed, there is then this isn't working how we'd anticipated it to, what can we do to help? So one of the things that we've done is we've tried to understand what is it about the service or the technology that isn't working in the service environment. So is it the pathways haven't been optimised in order to take advantage of the new technology? Or often we find there's an element of trust which isn't there. So if you put a virtual ward solution in, you have to get the hospital to buy in and the community staff and primary care all to understand A, who's holding the clinical risk for those patients, particularly on the waiting list for virtual wards, and B, if there are any issues with the deploying of the technology, who owns that and who needs to fix that issue. So those are some of the things that we've worked through, and we've done a lot of awareness, comms, and also just getting to the bottom of it really, because it's quite hard for people to surface the reasons they don't want to use something.
If we strip it back, in terms of the role that you do, is it a question of hospitals come up to you and say, how do we create the most efficient hospital possible using technology? Can you sort that out?
Yeah, we look at that and value for money. So my background is, apart from being a clinician, I'm also an accountant. Again, apologies for that. But that also helps in terms of being able to help with value for money and make sure that it's sort of best investment around taxpayers' pounds. We also have done some work with vendors as well who want to try and access organisations. So we've worked with them. Again, we are agnostic, but we'll try and make sure that they are pitching their services or they're addressing real needs. Sometimes we get people who come to us and they haven't quite understood A, how the NHS works, but B, the kind of needs that are being surfaced. So we'll help them with that kind of product strategy side as well.
Just a health warning as well. I wouldn't put these in bags for young kids because I've just broken the lid on that one, you see. So it's down there. Okay. Little health warning from me there. During COVID, everyone spoke about, embracing technology. And I think there was a feeling during COVID, we had to embrace technology, let's try it. Do you feel like healthcare is now reverting to norm and is less willing to try new technology?
We're seeing a bit of that. We're seeing that lots and lots of products and services were thrown at solutions or trying to fix certain problems. There is an element now of people stepping back to saying, is this working, is this embedded? But also what we're seeing is because the funding has constrained, and also we're looking to head into an election year, that changes buying behaviour as well, and it changes the ability of people to have risk profile. With the frontline digitisation money being cut and then digital budgets being cut, then people are actually tending to invest more with the bigger organisation because it feels less risky, is certainly what we're seeing.
Yeah, just final question. Mentioned before, you're never afraid to give an opinion, so I'm going to put you on the spot right now. What was your view on the NHS's deal with the US data firm Palantir to analyse vast amounts of public health data? Because it was quite controversial.
It is controversial, but I feel it's controversial for a different reason other than the fact that it's Palantir. It's less to do with the data that they've got access to and more to do with where the benefit's best. I'm really struggling to understand what's in it for NHS Trust, why they'd engage with it or systems, because it looks like NHSE will be receiving the benefits of it. And I don't understand, if you're a Trust Ops director or a medical director, what would you get from it that you're not getting from your local flow systems, your local systems that you have in place already?
Yeah, because it's not a huge contract, but it's more the significance of it. I think it's quite interesting.
Yeah.
Okay.
There's political significance to it, obviously, but I think that there is something about how people are then being asked to participate in something where the benefits are unclear, wouldn't sit with them, and there's no local money to fund actually participating in it. So I think for me it's going to increase the inequality that you have between trusts that are struggling to fix the roof and all of the other things that they have to do with their capital budget, and they can't migrate to cloud, put all of these other things in that are prerequisites for the participation in this system.
Thanks very much. Thanks. We're coming down to Jon Pickering now of Mizaic. We've got any golfers in the room? Any golfers? Any keen golfers? Yeah, there's a few in the room. There's a few. I was talking to Jon. I always say, tell me something about yourself that would surprise me. Well, I know Jon plays a bit of golf. I know he does, but he doesn't like to talk about it. And anybody who plays golf knows, that they do want to talk about it. So I said, so I said, Jon, what are you playing? I don't like to talk about it, Chris, but I'm playing off one at the moment. I said, are you really? And then every conversation revolves around golf. So he said, where are you from? I said, I'm from Kent. I said, because he's from Kent as well. I said, I'm from St George's, near Sandwich. I play St George's. I know where this is going. So I said, how'd you get on? I played really well, actually. Yeah, I went round. I played on the back tee. I mean, that's when you get too much detail. Played on the back tee. I actually played around with a pro. I went round with a pro, and then he finished it, and I beat him. And that's, but don't mention it because he doesn't want to talk about it. So we're just going to talk about, your business, Jon. Just explain what Mizaic do. Still playing off one? Yeah, okay.
Cheers, Chris. you did say you wasn't going to mention that as well.
Yeah, absolutely.
So no, we deal with the big paper problem in hospitals. So we help digitise all the historic patient medical records in hospitals and ingest them into our software to make them of use to a clinician at the point of care. We predominantly do that for acute hospitals, but we also do it for mental health trusts and community hospitals as well.
So give us a scenario, because we've all been into a hospital, and you go in with a particular problem and you don't know, or they don't know anything about your medical history. So give us a solution that you're fixing. How would that work?
So first of all, look at all the big paper libraries that every hospital's got. We empty those and we work with scanning partners to bring them into the software. Once we've brought them into the software, we apply some clever technology over the top of that, so we read all of the text involved in those documents. Obviously, it's unstructured, paper everywhere data, but we provide some structure to the unstructured from that. We make it indexable, searchable for a clinician to use when they're sat in front of us as patients. So we allow your historic patient medical record to become of use to the clinician instead of having to sift through a paper folder that's 400 pages long and they can't read 5,000 words per second. So that's
but you're still, in terms of the scale of your business, you're 40 staff, 5 million turnover. In terms of the digitalisation of patient records, you're sort of still scratching the surface, aren't you?
Absolutely. Yeah, we've got about 10% sort of share of the acute hospitals now. We've got over 20 NHS trusts that we're working with. but 90 of them have still got big paper problems. Forget what you hear in the press around everybody being nearly digital, 90% of hospitals being digital. That's not the case. They might have an EPR, which deals with the administration and day-forward aspects of all of us having the patient record, but it doesn't deal with your historic patient medical record, which is obviously of massive use in mental health, in when you've got complex treatments and a history of treatment in hospitals. A clinician needs to know about that when they're meeting you. So we are trying to revolutionise how that clinician patient experience to ensure that all data is available for a clinician digitally when they meet the patient.
I suppose it varies clearly hospital to hospital, but if a hospital says to you, we want to digitalize all our patient records, that process takes how long? I mean, it's going to vary.
Minimum 6 months. We've done it in 6 months for London North West Hospital during COVID as well. So they came to us to say that they needed to digitise quickly at the start of COVID. Before I joined, and in record time we deployed the software in 2 weeks and helped them digitise the majority of the patient records within about 6 to 8 months.
But if 90% still haven't been digitised, you can see how long into the future that's going to take. AI, I don't like to talk about it all the time because we obsess about AI. How important is artificial intelligence in your business? Are you doing any projects using AI?
Yeah. So it's increasingly important, but I've been to quite a few data and AI conferences recently. Specifically its use within healthcare. Obviously governance and how it's used is being widely talked about, and I absolutely agree with it. It needs to be used responsibly. So how we're using it at the moment, early next year we will read all of the handwriting as well as all of the text in the patient record, so we'll have the entire data set for every single patient within a hospital. That's the first aspect of it. And then what we've just done, which is a first in the industry, we think, is we've created a clinical advisory group from a group of CCIOs within our customer base that are helping us advise on what they'd want to find out. If you had a digital patient medical record, what would you want to ask it so that you've got vital information when you're meeting the patient without even going looking for it? It could be smoking, it could be last admission, it could be allergies, non-rhesus orders, it could be anything. But we're engaged with a set of clinicians at the moment to say, if we had AI available to us, what would you want to ask the data? And that's how we're using it, and we hope to have that available in the software next year.
Most people generally think COVID accelerated the healthcare sector's adoption of technology. You're not so sure though, are you?
No, I'm not. I think, to your point, I think what it did is it fired loads of procurements off for point tech solutions just to keep hospitals running. But what it didn't help was obviously large amounts of funding getting put to frontline services, obviously important and absolutely needed to happen. But then I think what it's taken away from is the importance of actually having a digital and IT strategy that you're executing on, and it distracted everybody away from that. So everybody got using tech, but there's now you're trying to sort of sweep that up into some kind of consolidated strategy that gives the people, gives the hospital a sort of clear path forward in terms of how they're going to mature.
Thanks, John. Our next speaker is Glenn Cooper, Chairman of Inovus Medical. There's a business in St Helens called Inovus Medical, amazing business. So much so actually, they've just won a KPMG award, one of the best businesses in the UK. Narrowly missed out on the global award. They finished runner-up in Lisbon. In fact, Emma, who's hosting the final panel, she was in the audience as well. One of the co-founders, a guy called Dr. Elliot Steele. He's mid-30s, an amazing speaker. Honestly, if he was here now, you'd be waiting off every single word. He's brilliant, he's imposing, he used to be a doctor as well. We couldn't get him, so we got Glenn Cooper instead, who's got a Suffolk accent. I think it's important to say that. Welcome, Glenn, good friend of mine. Just explain what Inovus Medical do.
We're specifically focused, it was interesting hearing the panel just before lunch. So we're in obs and gynae as our focus, and it's laparoscopic surgery, but it's training of the surgeons before they go into theatre. So the old style of theatre surgeons would be operations are done in a theatre and people watched, and it was watch one and the following day you'd do one and that's pretty traumatic if you're the person that the guy's only watched do the operation the day before, or the lady had watched the operation. And we wanted to replace that, and with the background particularly Elliot and Jordan had, they wanted to make that training into a MedTech business. And so we have a little thing called a box trainer. Word was used earlier, we're completely independent, agnostic of any particular instruments. And we also give a lot of haptic feedback, so we have models of everything that's required to do those operations, and we then take that information, feed it up into the cloud, and we can analyse speed, we can analyse movement, we can analyse how far they're moving out of a particular target area, and a whole bunch of other data. And as a result of that, feed back to the surgeon who's being trained and his supervisors what needs to be done to improve their technique and using technology to its very highest level. So that's broadly what we do. So I'm a farmer from Suffolk. I understand nothing about MedTech. I'm just the chairman and investor. But I've found, particularly in the area that we operate, and some of the points that are being made earlier, it's about being free and easy about discussing all of that and understanding exactly what happened in the boardroom. So whereas before I'd be sitting in a boardroom talking about numbers, now we use all these medical terms, like the ones that were being used earlier. And when I first sat there 4 or 5 years ago, I'm going, you can't say that. And then all of a sudden you realise that that adds a complete richness to your understanding of what the problems are and what you've got to do to alleviate those problems.
Glenn's incredibly modest as well. He always says, I'm the most stupid person in the room. He's not. It's normally me. But his previous 2 businesses sold for over 20 million. His most recent business was a bollard manufacturer called ATG Access. He sold that for over 20 million as well. He does talk bollards a lot, but it was an inspired appointment by Inovus Medical to bring somebody in from a non-HealthTech background to hold them to account about business, and that's one of the reasons why it's been successful for. When I went to the KPMG event where Elliot was talking, he was asked this question, and it was about, and he gave one of the best answers I've ever heard, and it was about, you've got this simulator, it's much more technical than that, but you've got this simulator where you can, surgeons can practice and can operate as well, but surely there's lots of other simulators out there. He said it's a bit like being a tennis player, we give them a tennis racket and balls. Everything you do is so lifelike, and they showed a video. It was like operating on a person, but it wasn't. That's the key to your success, isn't it? HealthTech has to be lifelike.
Yes, I mean we can induce bleeds, so we could do anything you could imagine within the arena that we're operating, and it gives real haptic feedback, and the analysis between the tennis player playing with a tennis racket and the tennis ball is that feedback is the difference between playing with our instrument versus playing with a Wii to learn how to play tennis. And you ain't going to learn a lot from playing tennis with a Wii.
No, definitely not. Now, you're looking to expand your reach into the US. You've just secured major contracts with 2 companies, AAGL as one, and Hologic Incorporated as well. Just tell us about that, because you messaged me really excitedly late at night to say this is a game changer. Why?
It is. Well, first of all, the American market is 45% of our addressable market in our particular sector. We're specified by the UK and the NHS in terms of training, but this is AAGL, who is the equivalent in America, specifying that we are the platform they use for training all of their surgeons. So when a surgeon first comes in to start his training, he's using our equipment. And our aim through some software we have called Totem is that particular surgeon will follow and use our equipment as we move into other sectors. As he moves up the tree, he'll use our software because it's the stuff he learned on.
It's a bit like, though, people, pilots who have to spend so many hours in the air before they get, their wings, if you like. I mean, these surgeons have to have so much, practice before they actually allow to operate on human beings. I think I'm right in saying that your Totem software has carried out over 8,000 procedures.
Yep.
Yeah.
And we've been measuring that since probably about 7 months.
Yeah.
And in America now, we've set up a business in Florida. We've got our first American employees. We have a fully operational business now in the United States as well as here in the UK to support our growth.
Yeah, I've got the 5-minute warning. Can't wait for the 2-minute warning, what she does then. She did that for the 5-minute warning, so I don't know what's going to happen for the 2-minute. And I'm not going to be on stage for the 1-minute warning. If we just go through the panel and get one quick question or one answer from everybody, what does the future of health tech look like? You know, we talk about innovation and disruption. Who wants to kick us off with that? What does the future look like?
Okay, thanks for
I'll
putting
come
me
to you
on the
first.
spot.
Yeah, Formula One.
Yeah.
Take it away.
Colliding, worlds
Yeah.
colliding.
Okay, the lights are.
I think something that I can't tell what the future will be like, but something that I'd like to see is something that we've talked about, Chris, previously, which is going back to the points Lauren was making about what value in digital health and care actually means. And it's really looking at that concept more holistically and looking at it not just from the perspective of ROI, which of course is extremely important when we talk about health tech, but also looking at it from the perspective of, are we introducing tools that are reducing pressure on the service? Are we actually helping patients? What's the adoption? What's the experience? What's the impact in supporting things like net zero targets? For instance, something that we're doing now is developing a net zero calculator that sits on top of our virtual care platform to automatically quantify net zero contributions across virtual pathways. So that's something that I'd like us to move to. Whether that will be happening, sure, we'll be working hard to make sure that it is. But yeah, that's what I'd add.
Yeah. John, what does the future of healthcare look like for you and health tech generally?
I think the prediction being that there'll be a lot of prioritisation of budget around anything that's to do with preventative care and improving sort of patient pathways and flow through hospitals. That's the area that I'm directly involved with, is trying to improve that patient pathway. So I think the use of AI will, you say, let's not talk about it, but actually everybody is talking about it, but it's responsible use in healthcare, I think, to improve patient pathways and help clinicians make better, more informed decisions. Anything that sort of contributes towards that will be prioritised.
Yeah. Have you heard about that new fad where people jump into ice baths in the morning at like 5:30 in the morning? You know, you heard that? People who do that, you know, he does. Okay. Goes in there with his little pitching wedge like that, you know. So he plays out the water very well now. Lauren, what do you think the future of health tech and healthcare look like?
So I think that we look like we're heading into an election year, and I think that will change the funding streams. And I think it will also mean that in the near term, we're going to see a few more of these kind of bombastic statements around large amounts of budgets being released, but actually lots of people in the service saying, well, we're not seeing it and we're not seeing the benefit. So I think that's going to be the next kind of 12 to 18 months around what will actually happen. Assuming that there will be a change in government, I think that will then lead to another sort of 6 months around uncertainty whilst people get their feet under the table and they understand the brief that they're working with. But the hope is that we can then get some more sort of sensible funding around what I say boring basics. But again, going back to that kind of Palantir FDP point, there is an element around needing to level up, that you've got a lot of these kind of massive university hospitals, which is great, who can participate because they're at a base level. But we've got a lot of places, particularly those ones where they've got really like actual structural issues, either with PFI funding or to do with, you know, like the roofs caving in because they're old Victorian buildings, that really struggle to be able to have enough budget to participate with digital. So I would like to see any incumbent new regime coming in thinking about how they're able to determine that those things are able to be levelled up so that we don't have this disparity that we see all across England and the devolved nations.
Okay, Glenn, final word to you. Keep it short and sweet. What does the future of health tech and healthcare look like?
Am I allowed to be controversial?
Yeah, but don't do that with your tongue whilst looking at me. Seriously, you know, I'm going to look away next time. Okay, Glenn. Yeah. What is the future of healthcare?
I just wanted to know. Well, don't turn around, Chris, when I'm doing that.
No, go on.
So I'm allowed to be a little bit controversial.
Of course you are.
The two parts, really. For us, I do see continuing development and use of digital technology. So there's so much pressure on that will happen. In a normal commercial business, like the ones that I've had before and like the ones that Chris alluded to, if I was introducing technology, my first question was, what are you doing with the overhead? Get rid of it. And I think the challenge, and this is the controversial bit, is can the NHS stand up to that sort of scrutiny? So if the digital technology is making things easier and faster, is it going to wipe out the overhead and use the money for the doctors and the nurses and the clinicians? That's the challenge, and that's what I'm worried about not seeing.
No, and that's the problem, you know, because if you were to approach the NHS like a business, you would rip it up.
Yep.
You know, and start again.
But you'd get a rifle, wouldn't you?
Absolutely.
You'd kill most of them.
But politically, that just wouldn't work. Listen, thanks very much for everyone's time. Don't forget, don't get these things, perfect stocking fillers like that. Especially if you've got a girl as well, go for the pink ones, you know. So thanks very much for everyone's time. Thanks for our panel, and enjoy the next one. Thank you very much.